socio-economic progress, women's empowerment and education, and fertility decline. So you're rating them from the largest to the smallest. That's the first question. Second question, which of the following aspects of service delivery contributed most to decline in maternal and neonatal mortality? And I'm going to give you a number, but you can only pick two, okay? Evidence-informed and adaptive policy making, increased contact with health system, increased access to services with each contact with health system, availability of new interventions, and one more, improved quality of existing health services. I feel like we've just done an exam together. Please don't ask me to repeat anything. I trust you that you will have those two answers, and I'm going to be collecting your responses, and we will be using them in the upcoming panel. But first, we're going to take that global, regional, country look of where we are with neonatal, maternal mortality. Where are we? Where have we got to? And then the two presenters that you will meet. You'll meet one first of all, and then they're tag teaming, so you meet the other immediately afterwards, and they will do a presentation for you, for us. So Agbesi Amuzu and Una Campbell will be taking over the stage for the next 20 minutes. Yes, applause is necessary. Thank you. Agbesi, good morning.
Thank you very much, Femi. Good morning, everyone. Well, we are pleased to share our learning from country success in improving maternal and neonatal mortality. We present, hold on. Let me make sure I do this right. Can we need the slide to move? Okay, all right, great. All right, the study was founded by the Gates Ventures and the Bill and Melinda Gates Foundation. So over the past 2 decades, substantial progress has been made in achieving maternal and neonatal health. If you take, for example, mortality, maternal mortality, neonatal mortality, and stillbirth rate have declined substantially by over a third, and with faster progress for neonatal mortality rate, reaching closer to 50%. Similarly, the number of deaths have reduced over the same period. Well, current levels are still high, and trends may be slowing down, as we have heard. But we can also recognize that much progress has been made. So these achievements were made across all national income levels. Low incomes and, to some extent, lower middle-income countries bear the highest mortality burden, but have experienced notable mortality decline. Upper middle-income countries are doing particularly well. It is also noticeable that gaps in maternal mortality ratio are reducing, but efforts need to be made in neonatal mortality and stillbirth rate. Now, understanding drivers of progress in maternal and neonatal mortality and stillbirth is complex. Well, we approach this complexity through a transition framework for maternal and stillbirth and neonatal mortality. The transition framework is organized in 5 phases, from high mortality levels in phase 1 to lowest in phase 5, with corresponding threshold moving from one phase to another. These thresholds were inspired from published studies in obstetric transition and mortality, neonatal mortality. The framework has many advantages. First, it facilitates the integration of maternal stillbirth and neonatal mortality analysis and offers a tool for benchmarking country progress and improve our understanding of past mortality changes and its drivers, and inform strategic planning and programming in countries and globally. Secondly, it combines stillbirth and neonatal mortality into one indicator, as you can see on the x-axis at the bottom. That's effectively reducing a 3-dimensional complexity to a 2-dimensional problem that is easily comprehensible by our human mind. Well, third, it was based on historical trend observed in today's high-income countries and further validated in 151 countries. Most importantly, each of the 5 phases correspond to a typical pattern based on causes of death, fertility level, intervention coverage and inequity, health system factors such as financing, health workforce, and socioeconomic status. Due to some time constraint, I will not go through the specific patterns of each phase. The paper is in press and will be out soon, but allow me to just describe you quickly 3 phases. So consider a country in phase 1. So the country will have a maternal mortality ratio above 700 and a combined stillbirth and neonatal mortality rate of 80 or more. This country will typically have high fertility rate, around 6 children per woman, and women will face enormous access to care, contributing to low institutional delivery, around 40%, and very low C-section rate. Only the wealthiest benefit from the life-saving interventions, and there is mass deprivation. So causes of death in this phase are driven by infection, such as sepsis, causes related to health status, and peripartum complications, such as delivery complications and obstructed labor and the like. So, moving to phase 3, that is bringing maternal mortality between 100 and 300, and a combined neonatal mortality and stillbirth between 30 and 55, the country must reduce fertility to moderate level, around 3 children per woman, and address access to care, reaching high level of institutional delivery, around 75%, and meeting all C-section need. Patterns in this case will be consistent with a marginalization of the poorest groups, and causes of death due to infections and peripartum complication will decline substantially, while causes of death due to health status and health and nutrition status will rise. Sorry, this thing's going, it's going. Well, let's click If I can get to the right slide. Sorry?
You'll just say next slide.
They need to go back. They need to go back all the way to slide 7. Go back, go back, go back, go back. Well, next slide, next now. Well, reaching phase 4, let me keep going. Reaching phase 4 with maternal mortality between 20 and 100, and a stillbirth and neonatal mortality rate between 15 and 30 will mean that the countries must reduce fertility to almost replacement level, around 2 children per woman, and ensuring near universal institutional delivery with meeting all C-section need. Inequality gaps are substantially reduced, and causes of death are predominantly related to health and nutritional status, with infections and peripartum causes becoming less common. Note that in this transition, the SDG target seemed as ambitious, but they will take countries as far as phase 4. Much effort will be needed in order to reach the phase 5. So, when we validated this in 151 countries, we saw that these countries progress across the phases, with over two-thirds of the countries progressing in at least one phase, and 6 countries progressing 2 phases. Some countries did regress, such as United States, Venezuela, and Vietnam, went due particularly to increases in maternal mortality. Next slide. So, now coming back to the transition, next slide. Coming back to the Exemplar study, in neonatal mortality, the transition model helped understand the questions that we are asking, which were to what extent countries' positive outliers have meant rapid reduction in maternal mortality and neonatal mortality above and beyond the socioeconomic status. So we first identify a set of countries by examining how far they deviate from the average mortality predicted by the socioeconomic change. And this graph shows a scatter plot of the different distance between the average predicted by socioeconomic status for maternal and neonatal mortality. What you want to look at here is the bottom left quadrant, which includes countries that have reduced mortality well above the average predicted by the socioeconomic status. The selection of countries then was not linear. We had to select a few. We couldn't go with all the countries, and we took into account the geographic representations, data availability, feasibility of the study, and the opportunity for greater learning. You'll see that Ethiopia, for example, was included as an East and Southern African countries, the second largest country in Africa, with a substantial reduction in maternal mortality. India was included national as well as state-level analysis. Next slide. So we researched the literature, did extensive analysis, quantitative and qualitative analysis, assessing household and facility surveys, and a multidisciplinary approach. There is a section this afternoon which goes into detail, the detailed method, and further detailed results. I will now invite Professor Una to tell you exactly what these countries did. Thank you very much.
Thanks. So you've heard about how we selected the 7 exemplar or positive outlier countries, all of which had above average reductions in maternal mortality. Sorry, if we can have the next slide. I don't dare touch this. Okay. Okay. When we position the progress of these 7 countries along the maternal, stillbirth, and neonatal transition framework, we see that all 7 countries advanced 1 or 2 phases. For example, you can see that Ethiopia and Niger moved from phase 1 to phase 2. And all of these 7 countries present roadmaps that we can use to understand how we make progress to having substantial reductions in deaths. Next slide. So how did they do it? Well, as Bessie said, we developed a conceptual framework that looked at over 150 potential drivers of mortality. We systematically considered proximate drivers, such as cesarean section rates, intermediate drivers related to the health system, for example, facility births, and we also looked at more distal drivers, such as roads. 4 important drivers emerged: more contacts with health services, more content of services, so better quality, fertility decline and safer abortion services, and governments also deployed a range, multiple levers, to try to influence the health system. Next slide. So first, there were spectacular improvements in contacts with health services. In the pink boxes, we see the median and the interquartile range, so the average of facility births for 151 countries globally by phase. And we also can see that Ethiopia, for example, went from 5% facility births to nearly 50% as it moved from phase 1 to phase 2. Nepal went from less than 10% to nearly 80% as it moved from phase 2 to phase 3. So these are 10-fold increases in the percentage of women delivering in a health facility. How did they do it? Well, it differed by phase. They didn't all use the same approach. In the early phases, so the countries with the highest levels of mortality, they focused on generating demand for services. For example, using the community health workers that Atul mentioned in his presentation, the community health extension workers in Ethiopia, the ashas in India. The countries also expanded services themselves. So as they moved, they increased the numbers of health facilities and the numbers of human resources for health. So Nepal, for example, went from nearly 7 doctors, midwives, and nurses per 10,000 population to over 41%. So that was reaching recommended WHO levels and in fact surpassing them. Countries removed financial barriers using either conditional cash transfers, for example, the JSY scheme in India or the AMA program in Nepal, or via removal of user fees, as was done in Niger, in Senegal, and in Morocco. And with general socioeconomic development, advances were made outside the health sector. So we saw, for example, phone ownership increased in all countries. And Morocco, Nepal, Ethiopia, India all grew their road networks. And these were leveraged to create and facilitate linkages, particularly in rural areas. Okay. Women in all countries had more education. Okay. Next slide. In this slide, we dig deeper to look at the facility, the level of the facility where childbirth took place. And again, we see it varies by phase. In the graph on the left, we see that between phase 1 and phase 2, these are the high mortality phases, a lot of the expansion in facility birth took place as women delivered in lower level health facilities. These facilities are close to women. On the right, we see that hospital births dominate in those countries with the lowest mortality, so the phase 5 countries, where nearly 100% of births are happening in hospitals. How do we interpret these challenges as we redesign services? And how do we balance physical access, which is usually there for the lower level health facilities, so women are close to these facilities, with facility readiness and capability to provide life-saving care, which often happens within hospitals. Also, as women aspire to hospital-level care, in some countries they increasingly use the private sector, and there we have which is challenging to regulate. And there we saw burgeoning and potentially unsafe cesarean section rates start to happen in the private sector births in Bangladesh and in Morocco. Next slide, please. The second driver was improvements in quality of care. So we see, for example, on the slide on the left, that in Nepal, women had more antenatal care with skilled providers, okay? But that also was an opportunity to drive more content of care. So, for example, more women got their blood pressure measured. Okay. How is this done? Well, there were more trained health professionals, and Dr. Sudha, who will be speaking next, can attest to how they did this in Nepal. Key interventions which were put onto essential drug lists, and supply chains were improved. So Senegal, for example, made great efforts in improving its contraceptive supply chain. There were also explicit policies to improve the quality of care. For example, in India, from 2012 on, there were various initiatives like the Lakshya and Dakshata initiatives to improve quality. And data were also used to track intervention coverage. So Nepal used the DHS and their routine health management information system to analyze and report on progress, particularly progress in more deprived and remote districts. Next slide. Next slide, please. The third driver was fertility decline and safer abortion services. So we used Jane's decomposition approach to show that fertility reduction brought down maternal and neonatal deaths by at least 15% or more in all the countries that we looked at. And it's important to note that having fewer births means that countries don't need to just grow their services just to stay at the same level. How is this done? How was fertility brought down? Well, there was more use of modern contraception. There was better access to safe abortion services. And as we move more distally, there was later age at marriage in all the countries, and later age at first birth, fewer adolescent births. And also we had better women's education, more women's labor force participation, increased women's status, and declines in child mortality, and less restrictive abortion laws, for example, in Nepal and Ethiopia. And what the graph on the left shows is there we scored abortion policies in the 151 countries from the most restrictive, so those that didn't permit abortion at all in any circumstances, to the least restrictive. So abortion was essentially available on demand. And we see that countries with the highest mortality in phase 1 have the most restrictive policies. Next slide. Okay. We also saw that the governments in these 7 countries effectively used multiple levers to try to influence the health system. So there wasn't one solution. There was a political prioritization, sometimes of maternal health, sometimes of maternal and neonatal health, and sometimes on health for all. So not all the countries had the same prioritization, but all put in place other levers that helped support the improvements in maternal neonatal health. Having changes in laws, particularly for abortion, changed the options that were possible. Regulations were put in place to permit task shifting, and there was strategic planning. Now, all countries, all of you delegates will come from countries where you have policies, strategies, and plans. But these countries actually implemented their plans, and then they looked at the data and they modified the plans in response to progress that was being made. And they made systems reforms to enhance management and decision-making, for example, with India and the Rural Health Mission. This progressive implementation and the use of data meant that these countries had learning health systems. They were able to learn from what they were doing and redirect and refocus. The governments put financial resources in place and removed financial barriers via cash transfers and user fee removals. And some worked well in partnership with the private sector, like Bangladesh, to expand the supply and reach of services. And all worked in partnership with funders, international agencies, and NGOs to target specific areas of need. Also, there were synergies across health and non-health policies. I've mentioned that countries improved phone access, some dramatically increased road network coverages, but there was fertility decline, improved female education, legal policies, and secular changes in women's status. Next slide. So in conclusion, we've seen that there have been important improvements in mortality, but also heard that how to avoid stagnation and that sort of flattening out of progress, we need to work together for change. And also to learn from best practices, including from the 7 positive outlier countries. The Mortality Transition Framework is a useful tool to help interpret key dimensions of historic progress, but also current status, but also to think about future strategies as we move forward. The M&H positive outlier or exemplar findings provide a really rich body of evidence, including how strategies change as countries move from high to low mortality. One size does not fit all. 4 important drivers can inform our future efforts: more contacts with services, better quality of care, more wanted births, and most importantly, the critical role played by government leadership and by their ability to use policy and system levers to improve health systems. Thank you.
Thank you, Professor Campbell. So how does success happen? Dr. Zolfi, please come on the stage. Dr. Nana, sit on the chair. Dr. Meseret, a couch awaits. Dr. Siddha, find some space. All right. Your panel, surprisingly panel, as you walk on stage, the auditorium will erupt. It will. Yes. Welcome, everybody. It's so nice to see you on stage. I hope you're comfortable. Dr. Zolfi is going to be coming from a clinical perspective. Dr. Nana will talk from a health systems perspective. Dr. Meseret, Ethiopia. Dr. Siddha, Nepal. But we can also mix it up.
Yeah.
Okay, all right. So, 2 drivers. Instant reaction here. Speedy quiz. That have contributed to maternal and child survival. Dr. Meseret.
Well, thank you very much indeed for this wonderful event that we have been invited, all protocol observed. Let me first congratulate my leadership and the country Ethiopia. And also, I do appreciate we are a part of that exemplar outlier positively. We are much, appreciate this result. And the most critical role I can say is leadership and government commitment, making maternal neonatal health as a top agenda, not only at the federal level, but also even at the district level, with a massive mobilization of the community, and also placing the health extension program in place, having payrolled health extension workers. I can say 40,000 plus health extension workers working in 18,000 plus health posts, and also we have invested a lot across the health system. I can say leadership and political commitment really matters.
Political will is the answer to everything, isn't it not? That and educating women.
Sure.
Dr. Nana, 2 drivers, do not hesitate.
Yeah. It's interesting, coming from a clinical and public health background, the first driver that I'll say will surprise many people, I think it's actually urbanization. Rapid urbanization around the world, especially in sub-Saharan Africa, has been a synergistic aspect of all the 4 drivers that Dr. Campbell talked about in the last few minutes. If you think about it, rapid urbanization brings people closer to health services, so the access to health services improves. In addition, rapid urbanization puts people in contact, so social norms around facility births, going to antenatal care when pregnant becomes a bit more normalized. Modern contraception becomes a bit more normalized in society. So I think rapid urbanization cannot be taken for granted as we think about what are the drivers over the last 2 decades in getting us the progress we've seen so far. The other one is also non-clinical, non-public health, and it's really about women's, girls staying in school for longer, especially teenagers staying in school for longer. Delayed pregnancy, delayed first marriage makes a big difference. If you delay pregnancy into your late teens or early 20s, you reduce the risk of being in the category of having a maternal death or a stillbirth, or perhaps a newborn death. So I think those are really important. I can talk about, obviously, the clinical and public health areas that I know very well, but I wanted to start out with the secular aspects, which we can't forget when this audience is very much a clinical audience, a public health audience, programmers and researchers, but we need more economists, behavioral science, social scientists to help us really see the big picture of how we're making progress together.
Dr. Zulfi, why are you applauding?
Right. She's taken a lot of the points I was going to make.
So that was a good job. Round of applause. 2 drivers.
So if I can
Yes.
put forward 2.5 drivers, maybe.
I knew you'd be trouble.
So the first, I think, that really adds to the analysis that Igbesi and Una have done is the importance of continuity of policies. I think we forget about that as we look over the last 20, 25 years in terms of how governments have made progress. Many of these exemplar countries have done this while they've been agnostic to political change. They've kept those policies in place, and despite the changes of government, those policies have, even in the context, Nepal's an example, even despite a really difficult civil conflict, they were able to stay the course. So that's one. The second, I would say, the quality of services is important, but I think we should not forget the importance of evidence-based policies. So over this last 2.5 decades, particularly during the MDG periods, the progress that was made globally in understanding what works and how it works was behind the implementation of many of these policies. And some of those are not reflected in just coverage. They probably need to be measured in effective coverage. And my final half point, if I can make, I can't come to South Africa.
Well, in 30 seconds, because it's only half a point. Go for it.
So I can't come to South Africa and not mention one of my favorite quotations from Nadine Gordimer, who said, "The facts are always less than what really happened." So behind all of these analyses, quantitative or otherwise, are stories of people, champions, that may be in public health, or they may be in civic society who have been influential in change, bringing about change in each and every country that's on the exemplars list. And that cannot be measured.
That's right. Complimentary applause. I like that. All right. Dr. Sudha.
I think in Nepal, the credit goes to the political leadership and their commitment, which really led to sustained financing and prioritization of safe motherhood programs, and also that resulted in designing policies which were favorable, and like Professor Julfi just mentioned, fine-tuning policies based on evidence, which led to my second point, which Professor Una already explained, which was more utilization of the services. Nepal, as you know, is a mountainous country with very challenging topography and other issues with marginalization of people. So how to reach care to the most marginalized, that was the main driver. So with a focus on reducing inequities and improving the content and quality of care, I think these two, mostly government leadership with all the health sector reform agenda and access to services. And access depends on many other social factors like roads and education and women's empowerment, which I think we've done very well. And the challenge is so huge, it continues to be prioritized and focused, but so far we've come a long way, and I really would like to applaud the contribution of health workers. And we have trained skilled birth attendants, put them in difficult positions, and they've all contributed. And I'm sure people attending this meeting today are from situations like Nepal and some even more challenges. So big salutations to all of you, and I think that's how we did it. Yeah, thank you.
Dr. Sudha, I don't have a doctorate, but I am a student of body language, and your face is telling me that you have a question about Nepal. Am I correct?
I am.
That's spooky, isn't it? Please, Jane.
Well, it probably means I don't have much of a poker face, so I'll work on that. But I do have a question. I mean, I've never visited Nepal, but I've heard about the mountainous areas. So I'm very curious about how the government supported geographic access for people who were perhaps further away from the facilities, especially the facilities that have CMONC services.
Nepal has, fortunately, 50,000 community health volunteers, and these are all women. And they go to households and, thank you, and try to send women with all the necessary information, which we just heard in the morning, about birth preparedness. And the government put a lot of focus on developing birthing centers, small units added to existing health posts, where women could come and deliver. And we tried to train the nurses, like staff nurses and auxiliary nurse midwife, give them essential safe motherhood practice skills. So skillful human resource were deployed. That was in the beginning of our Safe Motherhood program. Now, more and more CMONC facilities were added. Nepal has 77 districts. In the beginning, when things were happening around the time we started MDG, only about 15 districts could provide C-section and in the entire range of CMONC. Now, all 77 districts have many hospitals which can provide CMONC.
Dr. Meseret, you wrote a secret private note, which is no longer secret or private.
Sure.
Would you kindly share it with us?
Oh, thank you. Thank you very much. My country has an amazing, coordination platform, I can say. One budget, one financing, and one reporting format, where we ensure quality and equity, because always we have two lanes. Both right will be for quality, left will be for equity. We are always adjusting this one, because our citizens are we are 100 million plus, and 83% of the citizens are living outside of the urban area, where we really focus the geographical disparity, where we give due support and special attention for our pastoralist community and semi-pastoralist community, and also for those disadvantaged community, I can say. So we are working very hard on expansion of the CMONC service, deploying the workforce in this equity area. We also give due attention for quality, data use for action. We also, increase the access with, mobile health and, nutrition service. I can say, in addition with this, the non-health determinants, our investment on telecom, road infrastructure, and also girls' education, women empowerment program, and nutrition, in fact, and WASH program can do a lot for this success story. Thank you.
Thank you. I'm glad I asked you what you were writing down. All right, do you remember about 30 minutes ago, I asked you if you would help us give us 2 answers so that we could actually wrap it into our discussion. So I've actually got a printout while Una and Agbesi were doing their presentation. So I've got the results here. So Dr. Zolfi and Dr. Meseret, I'm going to ask you about your responses, but let me tell you, do you remember the first question? For a country that you know well, rank the relative contribution to the maternal and neonatal mortality decline of each of these drivers according to perceived contribution from largest to smallest. Number 1. women's empowerment and education. Number 1. Way ahead of anything else. I love how you're applauding yourself, audience. Go for it. You're your best hype person. Number 2, government health programs. So that was number 2. Number 3, socio-economic progress. Number 4, international initiatives. Sorry if there are any donors, and you're number 4. Okay, and number 5, fertility decline. That was what the audience said, Dr. Zolfi, Dr. Meseret. What country are you going to pick, and what would you put as number 1?
Well, I mean, I can pick several, but this is so consistent with work across other exemplars, for example, those that have looked at family planning, women's health and well-being, nutrition. These social drivers are key for human development everywhere. And we can change the order a little bit. We might put family planning a little higher, but I think a lot is around the role of women, education, empowerment, reduction of disparities, the contribution that women make, not just to the health workforce, but also to society at large. And that cannot be driven by isolated measures. It's so much dependent upon other investments. So I agree with that listing. The hierarchy may change in one place versus another. But one final thing that I would say is that what we underestimate is the challenge that many countries have faced over the last some decades with other contextual factors, such as conflict, such as struggling against economic crises. And the real heroes in all of this are those countries that have risen up despite those challenges and being able to allocate resources to make that happen. Mm-hmm. And they've done it through national leadership, and they've done it through consistent evidence-informed policies. I agree with the downgrading that people have made in terms of international assistance. I think that has been important in many places, but what you do with that assistance is the key. And you see that across many exemplars as taking best value for money and putting greater health outcomes out of your investments.
Your face is saying something to me again.
No, I'm working on my poker face.
Go for it.
No, it's fine. Go ahead.
Right. Dr. Meseret, you said for your important drivers, political will. So our audience in the room said that government health programs was number 2, way behind women's empowerment and education. Are you going to have an argument with them during the break? Or do you want to persuade them that political will is more important than women's empowerment and education?
Yeah. It's a very, very tough question. I can say I'm here today because of the education. I'm an educated woman in the health leadership, I can say. And also, I can say I'm also the result of girls' empowerment and girls' education. I remember my dad was a base mentor, and my mom too, I cannot ignore education here. I can say it's a power. It's a magnificent power to change the world, bringing innovation. So how could I really discriminate education? So I will just put political leadership, commitment, and education and health, because health is,
put everything in.
Health, no, it's not everything. It's health is politics. Politics is health. Without a healthy citizen, how can you, build a nation? That's why even our House of People's representative taking a note to oversight health system, whether it is really reachable for every citizen down at the district. So I can really say women empowerment, girls' education is also a power. For the result, I can say.
Dr. Sido, were you surprised that the audience said for number 1, women's empowerment and education, and then the least important was fertility decline?
No, I think the audience is right, because even to access services such as family planning, you need women, educated women, empowered women. And I would still like to link the government's role to that, because governments are the ones that invested more resource in making education available to women. So ultimately, family planning does play a role, but it's one of the many components, and women empowerment continues to remain key.
So as we were getting ready for this plenary, one of the concerns of one of our panelists was that you might be wrong. I have faith in you. But one of our panelists said, but what if the audience picked the wrong answer? Dr. Nana.
No, the audience is absolutely right. I think what we're hearing, what we know, is that this is multifactorial. There's no one single intervention, no one single policy that will make the difference. And I think the chase or the search for that one policy is a distraction. What we need to be doing more of is a synergistic approach, and more importantly, looking at the underlying drivers of health in addition to health care. The average person doesn't need acute care or even primary care on a daily basis, but we do need to take care of our health daily through good air, good clean water, nutrition, all those underlying determinants where we know that where you're born makes a big difference, how much money your family makes a difference to your nutrition, to your ability to go to school, how far you are from the school. All those things synergistically provide the health foundation, and then once in a while, we need primary care or secondary care or tertiary care. And we, in the health system, need to be ready to provide that, but we can't forget the underlying systems of good health and well-being.
Dr. Sudha, go ahead.
I fully agree, and in Nepal also we've taken like a multi-sectoral approach, and I think the partners, we haven't mentioned the partners, their contribution also is very important, and I think this title of today's theme, the momentum going forward together, that's again another strategy I would say Nepal has chosen, because we have a basket funding modality where we had health sector reforms. So all of those factors which the audience has highlighted, they're all very important, but coming together, keeping the focus and priority on maternal and newborn health, those are key. And I think we've done it quite well together. Thank you.
Thank you very much once again. We will still continue to ensure the health and the well-being of our mothers and newborns. We have to continue the investment, because I don't think that this agenda will be closed as far as life continues. So that it's not only to achieve the SDG targets that we set, it's beyond SDG, how we ensure the stewardship and sustainability, government ownership. And my big call to action in this very amazing panel, I could say, the result has shown for the last 20 years. The end is 2020. Then after, my country has been hit by triple burden, I could say, the northern conflict, the war, and also the climate change, the big drought, the huge droughts that we face, and COVID pandemic. So this is a great call to action for the global community, for our donors and partners, to continue your support, in particular to sustain the gain, to reach the SDGs milestones that we said. I thank you.
Have the results of the second question that you answered 40 minutes ago or so. Which of the following do you think contributed most to declines in maternal and neonatal mortality? I mashed those two up. Number one, out there, massively out there, improved quality of existing health services. Nothing else was even close to that one. Number 5, availability of new interventions. Number 4, increased contact with health system. And number 3, evidence-informed and adaptive policy making. Number 2, increased access to services with each contact with the health system. So, number 1, Dr. Sudha, improve quality of existing health services. Was that a bombshell that the audience picked that one?
Agree, 100% marks to the audience.
Okay. Dr. Nana, were you surprised by that one out there?
Not at all,
No?
not at all. This is
Okay.
the work I do, spend
Yeah.
all my time thinking about quality of care. Once people access the services, what we do for them, do we provide the appropriate care to the right person at the right time? This is the challenge, and we've made lots of progress in the last couple of decades.
Dr. Zulfi, does it mean that those other potential contributions to the decline in the mothers dying and babies dying, are they less important? Should there be less focus on them? should we be upping focus on that improving of existing health services? Now I say out loud, yes, duh, of course.
So I think they are all linked, and in fact, what is
Sure.
buried within that overwhelming, quality of services is the progress that has been made over the last few decades in understanding the content of those interventions. If you go back to 20 years ago when, people did not really have enough understanding of quality interventions packed within antenatal care, or for that matter, newborn care, enormous progress has been made in terms of understanding what works better, what should be prioritized. So I think today we define quality services also by the content of those services, what is prioritized within the training programs of health workers. So I think picking them apart is a little bit artificial. So they are all linked and as part of progress. But I do want to say one thing. I mean, we are in this conference because this is a conference on maternal and newborn health. But the world is moving pretty fast, particularly post-COVID, into the recognition that to optimize child health and development, you need to look at the continuum across childhood, bringing in school-age children, bringing in adolescents, and a secret sauce in improving mortality for mothers and newborns is also to focus on adolescent girls. And you cannot focus on adolescent girls without bringing school children in there. They were the missing middle. They were the ones who suffered the most during COVID-19. So I think moving forwards, we've got to realize that for governments, for civic society, for families, for parents, this dichotomy into periods of greater risk is something that we needed during the MDG period. But now moving forwards, we've got to look at this more holistically as what is needed in countries to optimize child health and development across the life course.
Dr. Meseret and Dr. Siddha, sitting next to each other, we have Ethiopia as an example, Nepal as an example. Do you feel a certain amount of kinship? Do you see that you're doing similar things in order to get success? Or are each of you taking different approaches because you're in different parts of the world? Talk to each other for me.
I think Ethiopia and Nepal, we share many commonalities. You described your challenges. We had our own challenges. We had a huge earthquake in 2015, the COVID, the floods, the landslides, the political conflict. Despite that, one of the issues has been, the continued focus, sustained financing, and the work of all those thousands of people, in Ethiopia, the extension workers, in Nepal, female community health volunteers, and then the health workers working in remote part of the country. And government leading, prioritizing, financing, making the environment favorable for women and health workers at large. Lots of challenges, but we are getting there. And I think that's where we are in common. And let's shake hands to that.
Thank you very much. What could I say? It has been mentioned very well. We have common, things we do share. It's all about, having the landscape of policies and strategies from the global community, regional, implementing to the country context. With the driver's seat, who's going to be there, the government leadership really matters. So we do share. We have common, agenda, and because that's the center of the domain, the well-being and the health of mom and newborn, I can say. So thank you very much. I will also again shake hand of my sister. Thank you.
One of the things that we had to work quite hard at on this particular plenary is that we're always going to, but the challenges, but the but. And this isn't about that today. Today we're just saying, this is how it can work. This is what we've done. This is the progress that we've made so far. Dr. Nana, in particular, I quoted you at the beginning of the day because you were so bullish about where we are right now. What is possible? As we're doing the What is Possible Day, give us a vision.
It's a great question. I think the inspiration I have is from health workers around the world, health workers who are trained, well-equipped, motivated to provide quality care. I've seen it with my own eyes. I've seen managers supporting their frontline providers. I've seen health system leaders enabling, providing the resources, solving problems in real time. So that's what I've seen has worked, and that's what I know can work into the future. It's really rests with all of us, the health workers in this room, the scientists, researchers, clinicians. At the end of the day, we have a choice. We have, as professionals, as health workers, we have a choice to execute what we've learned at multiple levels. We can execute at 100% or 50%. We can show up at work and do the barest minimum, and we can show up at work and do the maximum. And a lot of it is the enabling. The enabling environment brings out the best in us. So I think as we think about what has worked and what could work in the future, we really need to think beyond the individual health worker, beyond the, as you say, the challenges here and there, really think about the enabling environment that we as leaders, managers, team heads, all of us are leaders in one way or the other. I think that's the aspiration that I have, and that's the aspiration I've seen, and I know that will take us forward over the next, 7 years until we get to 2030.
Mm-hmm. Dr. Zulfi, if you were sitting in the audience right now listening to this plenary, what would you expect to hear from them?
Well, I think we've covered a lot of the ground that the audience in this particular conference would have expected us to analyze the drivers, what are the major factors. But I'd like to build a little bit on what Nana said. And since we are celebrating the progress that has been made so far, so let me, in that celebratory mode, celebrate the role of community health workers. I've had the good fortune over the last quarter century of working with one of the finest and the largest public sector program of community health workers in Pakistan, the Lady Health Workers Program. They are public sector workers that are different from volunteers, and they have been doing a heroic job covering about 70, at times 80% of the rural population. They work under tremendous adversity, and I can today, with hindsight and 2020 vision, say with great confidence that we would not have been able to achieve what we did in the Millennium Goals for reducing maternal and child mortality had it not been for the contribution of these outreach workers, had it not been for this task sharing that was necessary to reach the poorest of the poor. And now that we are at the threshold of a new era where we need to move, as Una and Ekbesi have said, along this transition pathway to more facility-based care, we shouldn't forget about their role, because their role may change in some ways from being able to focus on mortality reduction to a much more supportive role to improve quality of care, and also providing the support and aftercare that many facility-based services provide. So that's a huge achievement worldwide in terms of generating, understanding the evidence around the role of outreach programs and community health services, and that really deserves to be celebrated.
Mm-hmm. Yeah. As we're sitting here together for 2023, I just want you to leave our Plenary 2 audience with something to have a chat over during their coffee break. Dr. Sudha.
I would say progress is possible and context matters. So whatever is your context, try to look at the evidence and keep your focused attention and sustain the efforts. That is my message. Thank you.
Mm-hmm. I don't think it's going to be Ethiopian coffee. I'm sorry, Dr. Meseret. But imagine it is Ethiopian coffee, something juicy to talk about during the coffee break. What are you going to leave us with?
Wow. Let me say conducive environment for mother and newborn. With a background of selfless health workforce. I'm not only saying health extension workers, I could say tireless health workforce and supporting staffs really matters. Because we are talking about the life of mom and newborn, the current and the future generation, and who is going to provide the care? It's the human being, the health workforce. Let us celebrate and recognize the effort of the tireless entire workforce in my country, and also for the selfless trust that they provide for us, our community. Thank you.
Thank you. Dr. Zulfi, I want to hear debate in the coffee break. What are you going to leave us with?
Oh, I hope a recognition that we have still a mountain to climb. You know, in the words of the late Paul Farmer, he said, beyond one mountain's another mountain. Our challenge right now is that we have learned how an event like COVID-19 can indeed develop, regress so many things in global health, and also highlight so many gaps that we have currently in our understanding of what I talked about, the continuum of care across childhood. So I think we need to now look at the future through the lens of how can we do even better? How can we now aspire to provide continuum of care, not across through childhood, but also linking, as I said, aspects of women's health, and importantly, also recognize that women's health is much more than health during the reproductive period. The greatest gap in COVID-19 that we saw was in the care of the elderly. So looking at continuum of care across the life course, looking at women's health and well-being through a more holistic lens, which goes beyond health to other multisectoral drivers, that's our combined challenge. And I hope in a decade from now, we will come together and celebrate our achievement in that quest.
Dr. Nana, the mic drop moment is...
I think for me, what I'd love the audience to leave with is thinking about what matters most to the pregnant women in the context in which you work. I was really moved, as many of you, I'm sure, were by Treasure's story. I think that's the name, Treasure, is that correct?
Treasure.
Treasure's story. I was moved to tears, and I wonder if she could tell the health workers who attended to her that day or those 4 days what mattered the most to her at the time when she came in. I wonder if her outcome would have been different. So I think, we health workers, we do the best we can, but we do have a lens through which we look at the world, which is supplier, healthcare work lens. I think we need to put ourselves in the shoes of our patients, our clients, our communities more, and just find out what's on their minds, what makes the most difference to them, and see what we can do to meet their needs, and we will end up with a better health system when we health workers meet the needs of our community. So that's it.
Dr. Nana, Dr. Zulfi, Dr. Meseret, Dr. Sutta, thank you so much for showing us, telling us, unpacking how it's possible to reduce neonatal deaths, stillbirths, maternal deaths. Thank you for your positivity. I really appreciate it.
Thank you.
It was great.
If you have looked in the program, you would have seen over 180 sessions. This was just one of them. I've given you an extra few minutes in your coffee break, which will happen on the ground floor in the expo hall, so you can study the next session that you will go to. I have one more thing for you to do. Please stand up. Turn around.
Turn towards you.
Go to coffee. Thank you, everybody.
Thank you.
Femi.
Thank you.
Strong health systems that